improvement around the ABCS. So we have real data for the first 2 years of the initiative, and about 115,000 events were prevented. For those of you methodologists out there, we actually came up with a methodology to count the event that didn't happen. I can share that citation with you if you're interested. 2019, we'll have the final data on the number of events that were prevented over that 5-year period. We're predicting it's going to be around 500,000. It's not 1 million, so we fell short. But again, because of the work of all of the partners listed here and work going on in 50 states, we think there will be a substantial reduction. But basically, we're not getting to 1 million. So we knew probably midway through 2015, based on the publications of others, I look at Steve Sidney in the room, we relied on you, Steve, every step of the way, and others. But we were beginning to see that we probably were not going to hit the targets, and therefore would not deliver 1 million. So 2015, we also had heard a rumor that there was going to be an election, new leadership. And we didn't know whether the new leadership, red or blue or whatever color, would care about heart disease and stroke prevention. But we basically sat around a table, a small table, and said, we're not going to get to 1 million. We were given the charge to get to 1 million. It's a #1 killer, it remains a #1 killer. And we know what works, it's just not happening everywhere for everybody. So we said we're going to try to design a new phase, and we're just going to keep on moving forward until someone tells us not to. And so far, no one has said no. And so we're beginning the second quarter of the second year of the second 5 years. And we have CMS on board now. We have, I will say we had CDC on board, and we have had, but there's been more change at CDC, as you know. So we have not yet met with the new director, but we will shortly. And again, I feel pretty confident that what we have to offer will be accepted and embraced. So we are going forward. And what we're fighting against is what you mentioned, and many of you already know, and many of you may have published the articles that are reflected here. But we are seeing a slowing in the heart disease, cardiovascular disease death rate decline that we've enjoyed for the last 40 or 50 years. That decline, that slowing or deceleration, is probably due to decades of obesity, physical inactivity, and diabetes hitting the event rates. We all knew it was going to happen, but it is happening. And an unfortunate thing for our efforts is that it's really started to slow around 2009, and as I said, we launched in 2012. So we don't like this flattening, and we tend to call it the cardiovascular disease headwind. It's happening for stroke as well as heart disease. These data are at the county level. So this is the thing that keeps me up at night. It's a complicated slide, but so I'll just walk through it. First of all, we're talking about 35 to 64-year-old age group on this slide. Young people, 35 to 64-year-olds. We're looking at a period of 5 years, 2010 to 2015, and these are county level data. So in red, you see increasing cardiovascular, not event rates, death rates. In the gray are areas of decrease. This is not a stroke belt issue only anymore. This is Maine to California. And you see over 50% of the counties showed that increased death rate, over 50%. So I'll go through just briefly what we did in preparation for combating these increases that we've seen, the deceleration that we've seen. We did additional modeling. We engaged 3 different modelers. That might not have been the best idea. I mean, there's an expression about no modeling is perfect and all is bad, or some is useful. So then, of course, we had to try to integrate what we learned from the 3 different modelers, but we asked them to look at these risk factors. And I'll just put a circle around particulates because I know that's particularly important here in my previous home state. And we took the outputs from these 3 models. We asked them to look at a 5-year period and a 10-year period. And this is part of the takeaway. This is the integrated take-home message. When you look at what prevents 1 million events, you see that the blood pressure control and cholesterol and smoking are the heavy hitters. This does take a little bit of explaining. You would know right off the bat that some of these are working through each other. In other words, sodium reduction has its impact through blood pressure control. The aspirin data that are modeled here are for secondary prevention, and so we expect in this phase of work, we're working on primary and secondary prevention use of aspirin. So we expect more events to be contributed by better use of primary prevention. And then physical inactivity, of course, getting more physically active is incredibly important for more things than cardiovascular disease. But improving physical activity does take a while to manifest in actual event reduction. So that's why it looks so small there. And then, of course, the contribution from cardiac rehab are for second events, which are important to prevent. So this is the cartoon of the new design. In the past, we really focused on those public health actions and the healthcare actions. But we made no headway at all with the stubborn disparities. Some of you may have seen the publication this past week from CDC about the difference in outcomes, death rates for blacks and whites. And still there's a 21% difference in mortality rate for blacks and whites. What we decided to do in this 5 years is to select some priority populations who have a very high burden of disease and try to gather the right partners to help address those disparities. We couldn't pick all of the places where there are disparities, all of the subpopulations, but we picked a few. And so now we have this tripod. And I'll just flesh that out a little bit. Up in that upper left corner are the public health actions. We are sticking with tobacco because there is more running room there, more improvements to be made. We're actually sticking with sodium, even though we made no headway whatsoever in reducing daily sodium consumption in the first 5 years. But this past week, Scott Gottlieb, the commissioner of FDA, gave a talk and actually confirmed that he is going to continue to pursue the voluntary sodium targets that FDA issued previously, but we were afraid that was going to be rolled back. But he is on it, so we are very hopeful there. And we got to add physical activity over on the public health side. So this is community design and access and peer groups who can help individuals become more physically active. Public health action up in the left corner. Over on the right corner, we're sticking with the ABCS. We're sticking with who brought us to the dance because there is still room to run, certainly as you've already heard and you know from your work. We're adding a focus on cardiac rehab, and then that engaging patients in heart-healthy behaviors refers to what can happen in a clinical environment that could help an individual start to practice those healthy habits. They're reinforced over on the community side, but what could a clinician do? Our major focus on that side is home monitoring of blood pressure. How can we engineer and help support that practice, which turns out to be a better way to manage hypertension, to enable that individual, just like you would equip a diabetic to understand their blood sugars and check them and appropriately administer treatment. People with high blood pressure can do an enormously great job of monitoring their blood pressures at home if they're in close communion with their clinician. So our third bucket or third leg of the tripod are these priority populations, which we selected based on the evidence of a disparate outcome, well-positioned partners, and interventions that work. Clearly with African Americans and blacks with hypertension, we've seen great improvements in awareness of hypertension and in treatment, but the control rates are lagging far behind, leading of course to a greater burden of chronic kidney disease, stroke, and heart attack. The 35 to 64-year-olds, very frightening rise in event rates and death rates. Those who've already had a heart attack and stroke, and then individuals who have a mental illness or substance use disorder, very high likelihood of cigarette use, tobacco use. So those are our focal points. So, these are the strategies that we're starting with, and also shows you the targets. Really ambitious to think about a sodium reduction of 20% at a per capita level, but that's where we're aiming. I won't walk through these, but again, these are the public health strategies. It may not be all that we are focusing on, but this is a good starter set. And then on the optimizing care, I highlighted a few things, but really what I've learned about the work that you're doing is that you're already doing a lot of this. I tried to pull out things that I thought might resonate with your work or complement what you're already doing. And frankly, what I haven't learned much about in looking at the materials is whether your systems are connected to community groups, to faith-based organizations. Are you making that bridge? At CDC, they call it the clinical community linkage. It's all one word. I will tell you, on the other side of my family at CMS, they say patient-family engagement. That all is one word. So it's good to know your federal agencies are focused on these things. It doesn't always translate into the actual, how do you do that in the field, but the concepts are very much on those federal minds. So again, I won't walk through these, but we are, again, picking targets. We are shooting for 80% performance in blood pressure control, appropriate statin use, and the delivery of tobacco cessation intervention, and 70% cardiac rehab. Alrighty, in terms of the priority populations, just to give you a little bit more detail, and again, those are the criteria we use to select the priority populations that we would choose. We're encouraging our partners, if the priority populations we chose don't resonate with you or your community, the people that you care for, please pick your own, but you might consider using a similar criteria for that selection. The particulate is new for us, very new for us. How many of you are familiar with PM2.5? Yeah, I wasn't. And I'll just show you here. We'll go over, first I'm gonna just run through a couple of the newer parts of Million Hearts. I'll do a little biopsy on a couple of the new things. In terms of cardiac rehab, are any of you program directors or somehow connected to your cardiac rehab programs? Have your cardiac rehab programs been eliminated? Anybody's gone out the door? Doesn't offer those anymore? Okay. So back in 2015, we did a survey of our partners to ask, if we have 2 years left, what have we not done? What do you want us to try to tackle? What could we lift up and try to get more traction on? And it was remarkable how many people brought up cardiac rehab. Many people have been publishing about the low participation, low referral, low enrollment, low participation, and yet these dramatic results in reducing all-cause mortality, cardiac mortality, improving medication adherence, improving quality of life. So what can we do about these low participation rates? And usually good, even though there's a copay, there's good federal and private coverage. So these folks came together back in 2015, they've created an action plan, and they've committed to an aim. I highlighted the partners that we have, or the members in the collaborative from California. Kim Newland, who leads the cardiac rehab program at Sutter Health, is just kicking off a cardiac rehab quality improvement program with 8 of the Sutter programs to initiate, to implement one of the best practices. So we're excited to follow their progress. This is the action plan, including building equity in terms of referral, because there are disparities by race, ethnicity, and gender. This is a product of that collaborative, which actually tried to not only throw the gauntlet down for an aim over the 5-year period, by 2022 reaching 70% initiation among those eligible, but quantified the impact that will have. 25,000 lives saved and 180,000 hospitalizations prevented each year. Another output from the collaborative are 2 funding opportunities to explore community-based cardiac rehab and how rehab might be delivered for older people, a more effective model. What do we need in cardiac rehab? We need a number of things: greater awareness of its value among both clinicians and family members and patients. But we need ways to deliver it that are efficient and effective and patient-centered. So I know Kaiser has a program of telecardiac rehab. The VA does it. CMS doesn't currently pay for that, but there is a strong desire to demonstrate its effectiveness and then arrange that payment model. So this is just a schematic, a photo of what PM2.5 looks like. PM2.5, very small. It is exposure to PM2.5. It can come from diesel, from exhaust, from wood fires. It actually increases the risk of heart attack and stroke, as well as rhythm disorders. So people at high risk, those who've already had an event, turns out people who are, the groups that are at risk are those with prior cardiovascular disease or lung disease, the young, the elderly, and also those with inflammatory conditions. I won't go through the pathway here, but it is published. There are still gaps in our knowledge, and the place where we've landed is our role is likely in awareness raising. When surveys have been done to understand whether even healthcare professionals know about PM2.5 and how to mitigate the risk, awareness is very low. So whereas we're after environmental and policy changes in many of the other aspects of Million Hearts, in this one we are working on awareness. I'm going to slip on. How many of you are leading or participating in some program to facilitate home monitoring of blood pressure? Is that a regular part of? Yeah. Great. Awesome. This is just clipped out of the guidelines, strong recommendation for out-of-office readings. I'll just say briefly, we believe the evidence that shows home measurement done accurately is a better reflection of someone's blood pressure. The patterns that can be generated from home monitoring are more reliable for clinical decision making. But there are a lot of obstacles in the way of making that an easy practice. There's some places that have cracked the nut, but others are still very much in the development phase. Our team is working on these obstacles with many others, experts around the country. And I'll just quickly say, there is an ideal system. I think these are some of the characteristics of what an ideal system would be from a patient standpoint, as well as from a clinician standpoint. And then, are we there? Do we have these things in place? I'll say a progress report on these from right now is that the guidelines helped establish that very compelling case for out-of-office readings. There is a new billing code that was established in the physician fee schedule in November. My understanding is it has some rough edges and will likely be replaced, but there will be a billing code that will permit billing for not only the receipt of those readings, but the analysis and the return of advice to the patient. There'll be a new performance measure. NCQA owns that blood pressure control measure, and they have put the measure out for public comment. It does consider out-of-office readings, and then that measure will get embedded in the federal programs. The other things I would put either in yellow or in red, but this business of activating people with hypertension to manage their own blood pressure, a lot of these other system pieces have to be in place before an individual will encounter anything but resistance to the idea of trading blood pressure readings and advice with their clinician. There is a national group we've pulled together to help advise us and to create the roadmap. And then I'm going to quickly move to this. What is that? Does everybody know what that is? Yeah. This is, I thought I would be bringing news to you, maybe a few of you, and then this week, New York Times, Washington Times, and I think the Wall Street Journal all came out with articles about this. This is a Joule. Joule is the latest, hottest thing in e-cigarettes. I sat next to folks from the Truth Initiative and the Schroeder Institute a couple of weeks ago who shared these slides with me. And when the Truth Initiative person was making his presentation, I was sitting next to him and he was visibly shaking because this is the first e-cigarette that has frightened him. All the other e-cigarettes have a lower dose of nicotine than this little thing. So not only is it sleekly designed, it looks like a thumb drive. Kids in schools are able to smoke under their desk, and then they put the device on the desk and the teacher can't tell that this thing is there. This company is arranging a curriculum to take into schools to advise the kids on the fact that they should not be smoking, they should not be using nicotine. And this company is also paying the schools or granting, I'm sorry, I don't want to, let me be careful here. They have created a curriculum for junior high schools to make sure that they know that they shouldn't be using nicotine. This is very frightening. These are little pods that are attached and they're flavored, as you can see. In addition, this is the scary slide. Because the concentration one gets, blood level concentration from this device is equivalent to a cigarette, as you see. This is what has frightened them, because in the past, the nicotine experts, the tobacco experts have said they don't really expect, they expect the e-cigarettes to be used for those who want to quit smoking, and the doses were not high enough to think they were going to hook a whole new crop of people. But this changes the game. And this is the final slide I'll show on the Joule. Complicated slide, but all of the lines are other types of e-cigarette products. The red line is Joule and its market share over an extremely short period of time. This, keep your radar up for this, because as we've seen the tobacco prevalence fall, particularly in cigarette smoking fall in young people, this is a warning signal for us all. So, with all those challenges that I mentioned, why am I optimistic? Why do I think this 5 years for A Million Hearts and all the partners that have been involved, why will we make headway this 5 years? Particularly when we look at the, you could call it burden or you could call it opportunity. These are national numbers on the people who are not yet safely controlled or managed in terms of their risk factor. What I'm optimistic about is that we know what works. And what I'm also optimistic about is that it's working in California. The slides I'm going to show just quickly, just a few, come from the CDC's International Heart Disease Atlas. If you haven't used it and you're interested in data by state, it's really an easy to use tool. What I'm showing here are avoidable heart disease and death rates per 100,000. That is deaths from heart disease or stroke in males, females, all races, at age less than 75. And you see this wonderful thing going on along the coastline. It's pretty awesome from data of 2013 to 2015. Now there are definitely some red areas. You can look at this by, for example, physical inactivity. Interesting match there. But it does bring up the idea of that linkage into the community. What are the public health connections that you could make that help your patients get and stay healthy? Looking at the same map, but putting an overlay of cardiac rehab sites. These again are data from 2013 to 2015. And we've definitely got some areas that might be better served by a remote telehealth program. And then here I chose to overlay the federally qualified health centers, who are good partners for your systems, as Kaiser has demonstrated. So again, the challenge is, how do we take what is happening along the coast in California and take it border to border, north, south, and east, west? What also gives me great hope are high performers like these. Over the last several years, we've been able to recognize 6 places in California, 3 of which are community health centers, for achieving blood pressure control rates of 70% or above. And frankly, under the skirt, it's 80%. We're looking at folks that are above 80% here. Extraordinary progress, and in very challenging populations. These folks have been generous with the lessons that they've learned, with the teams sitting with us and helping us understand why they chose hypertension control as a priority, and then how they achieved it. Really aggressive outreach to reach those folks who are not yet under control, and a myriad of lessons, many of which we've tried to capture and have available for you. But thank you for these outstanding 6 places. And then these are the other reasons that I'm so optimistic, is that we have teachers who are willing to teach, and change agents, as Hattie said early, and then Hattie there at the center of the action. And Jim, I tried to find a picture of you, but I couldn't find one. And Liz Helms and others who have really helped lead the way. So with that, I would ask that you keep your ideas coming to me. If you've seen anything in this slide set that doesn't ring true or that you feel that we should be doing differently or more of, I hope that you will reach out to me. Thank you very much.
So it's great to be here. I was just, by the way, I'm going to finish in about 7 minutes. I'd like somebody to wave their hand at 7 minutes to let me know. Maybe I'll run 30 seconds over, but I remember, I'm just going to reminisce before Hattie leaves the room here, that 10 years ago was the first one of these, and she was up here struggling to get anyone to buy into this kind of right care concept, and I think everybody was rolling their eyes in the room, yet somehow she got this thing going 10 years and make incredible progress, and it's really, every time she asks me to speak, I can't say no. So I am here, but it's an incredible effort. Clap for Hattie. So I'm going to talk a little bit about what we're doing, and I have a question here. This is a tough question, but we know the rate of MIs are decreasing, but are they decreasing at the same rate as these other groups? And that is a true or false question here. And we're hopefully getting your curiosity piqued. Health disparities is a big, big issue. We pride ourselves on being a diverse country and a diverse culture, and yet we have health inequities. And so do I get to see the answers or not? One more. So everyone thinks that's false. I think that's probably the correct answer. The reason I say that, we've been looking in our system, and we haven't eliminated the disparity, but the rate of decline is actually the same. And many of you may have seen an article published in the New England Journal looking at Medicare Advantage plans, and they confirm that at least in the Medicare Advantage population, there are no cardiovascular disparities in our system for only Medicare, and that's not true of commercial, but they didn't look at commercial. So I'm fessing up a bit. We haven't mastered this thing, but I think you need to have some focus on different ethnic groups and not just look at your entire population. That's the take-home point. Here's our data showing drops in acute MI is the whole thing, and then we separate out STEMIs, and I have data that you're not seeing that shows similar identical slopes for the various races and ethnicities, but there is still a difference. So let's move along here. Another question here. We tend to look at HEDIS and NCQA measures, but look at those 5 factors and answer the question here, which one of these are not measured by HEDIS but are important in reducing cardiovascular mortality? So let's go. There's only 65 left. I thought we had 71 before. I'm not sure what happened here. And the idea here is I want to get people thinking. I know Wright Care emphasizes the publicly reported measures, but there's many other interventions that, prior speaker talked about that I think are just as important, and we need to be thinking more holistically. So let's keep going, and then my 7 minutes are gonna go quickly just with these questions here. So I'm gonna maybe just cut you guys off here if I have to. All right, so it looks like some of you said all of these. It's a trick question. They're all important, but nobody publicly reports screening for AAAs. Obesity is a little tricky. It's publicly reported if you measure BMI, but nobody measures whether you do anything with your high BMIs. So we do a great job at measuring how obese our members are. Fixing that is a whole nother thing. So I think the correct answer really is the first three of these things. And even hypertension, we don't actually measure the control rate, but not the identification. So trick question here, and maybe that's why we're all over the map. I want to talk about a couple of these exercise